So just to reiterate, Exam 5 is Monday and Tuesday of next week, and Exam 6 is also Monday and Tuesday of the following week. So Monday at noon, Tuesday at 4, same for 5 and 6. So they're both at the same times.
So the testing center has to be done by 4 o'clock on Tuesday, right?
Testing center has to be, those that are taking the Internet Exam 5, they do have to be done with the exam by 4 o'clock, done with the exam by 4 o'clock on Tuesday. The reason for that is that Tuesday people will be able to leave with their exam after they complete their exam, so you don't have to come by and pick it up. Monday people, you'll be able to come by my office and pick it up from me on Monday. I'll be there at noon, which is the same time that we typically have lecture. So just drop on by, pick up your exam. Keys will be posted on Wednesday. Also, the curve will be posted on Wednesday, and the sign up for Exam 6 will be posted on Wednesday. So all of those things will be done so that you'll be able to get business taken care of a little bit earlier and figure out what you're going to do for the rest of the semester and whether or not you want to take Exam 6. So as I said, curve will be calculated on Wednesday. All right, so let's get this show on the road here and finish off our lecture content. We were discussing the effects of pregnancy on mom. Overall, mom's organs and organ systems become very well vascularized, and we'll see a little bit more about how much more vascularized in just a little bit. The placental hormones. The placenta is in its formation in the first trimester, and that's called the placentation. Becomes mature at the end of the first trimester, and then maintains the pregnancy throughout. The estrogen and progesterone are being produced by the placenta, but in very, very low quantities during placentation, and then the levels are sufficiently high enough after maturity of the placenta to take over the pregnancy and keep it sustained. Hair and nail growth, great. Hyperpigmentation of linea alba gets a little bit on the browner side, and chloasma, mask of pregnancy, sometimes some women get, and that is due to those hormones. Breast tissue growth, the breasts are starting to prepare themselves to become lactiferous units, and prolactin will be released later on, and then breast milk will be produced. But estrogen and progesterone are basically, in my simplistic way of thinking, it's just building the factory, getting the equipment ready for the production of milk, not the actual milk production itself. Ligaments of the pelvis become lax at the very end of the pregnancy, because at the very end of pregnancy we have very high estrogen levels. Uterine lining is, progesterone, remember, is exceedingly important for maintenance of that uterine lining. Estrogen, of course, is going to help promote that too, because it also helps with the rebuilding of the uterine lining after it is normally left. So combined together, they're keeping a nice healthy uterine lining for the placenta to get its nourishment for the fetus at that time. Corticotropin-releasing hormone indeed promotes the release of aldosterone from the adrenal cortex in a pregnant or gravid woman. This is not the usual thing, and so pregnancy actually allows our corticotropin-releasing hormone to actually cause aldosterone release. This will cause sodium retention as well as fluid retention, and indeed is the one of the major causes for edema or puffiness that women will experience during their pregnancy, especially at the very end of the pregnancy. HPL, human placental lactogen. It is misnamed. So when you hear it, what do you think? Yeah, breast milk. Wrong. So HPL is not for breast milk. They thought it was, and they made a mistake, and see, we get to live with their mistakes. You know. So HPL, human placental lactogen. They came up with another name. It's really long and complicated, and actually I don't even like to say it because I actually trip over my tongue in trying to say it. So we will stick with HPL because it's easier to say. But if you do look it up in a book, you'll find out it has a completely different name that indicates what it does. What HPL does for us is it's going to promote maternal fatty acid metabolism. In other words, it's going to shift mom's preferred cellular fuel away from glucose and to fatty acids. because it doesn't mean that there's less glucose in the system. It means we want glucose levels to actually be a little bit higher than usual because we are feeding the baby. So we're going to mainline glucose to the developing fetus. So that's what HPL is actually all about. Switches mom's metabolic preferred fuel to fatty acids and then allows for a higher basal glucose level, which then will feed the baby. The problem with HPL is it can actually create some gestational diabetes in women because it interferes with maternal insulin activity. It doesn't mean that we don't produce insulin. It means that the insulin that is being produced is kind of spotty in its effectiveness. And remember, insulin is needed to get glucose into the cells. Well, because the cells are now switching their preferred cellular fuel to fatty acids, the glucose that we would be bringing into the cells, because now our insulin's not doing such a great job of allowing that to happen, again, also promotes a higher basal glucose level and can actually be so serious in its effects on some women that it actually truly does produce gestational diabetes. So what this means is people with gestational diabetes, does anybody know what their blood glucose levels are? They're high. That's why it's called gestational diabetes. Remember, in any form of diabetes, blood glucose levels are high. And so in gestational diabetes, it's because of HPL. That's why it's called gestational diabetes. HPL, and these individuals are too sensitive to the effects of HPL. And so their blood glucose levels go really high. And what do you know about feeding the baby? We're feeding them a lot of sugar. What happens when you feed somebody a lot of sugar? They get fat. That's the main problem with gestational diabetes. It creates for very large infants, and very large infants are hard to deliver through the birth canal. And so that is the problem with gestational diabetes. Creates for actually a very traumatic delivery experience. Human chorionic thyrotropin, HCT, raises the metabolic rate, acts just like TSH. Remember, TSH is called thyroid stimulating hormone and stimulates the thyroid gland to produce thyroid hormone and therefore raising the basal metabolic rate. Physiological changes. Now remember, just like gestational diabetes, not everybody gets it, just a few women get this. And so all of these things that I'm talking about, some women will have more of an experience of some of these things than others. Some will not experience them at all. And so GI system morning sickness. There are some women that do indeed have problems with morning sickness, and this is due to their inability to acclimate or tolerate the rising estrogen and progesterone levels. So these estrogen and progesterone levels are rising throughout pregnancy. They are helping the baby to develop and grow. Mom's systems also are developing and growing a little bit more effectively with that. And some women are very, very sensitive to those elevations. Typically, they develop tolerance, but not always. Some women have nausea and vomiting of pregnancy throughout pregnancy, and we all should feel very sorry for those people. It's not anybody, I don't know about you, but hurling is not, on a daily basis is not considered a fun event. Motility of the gastrointestinal tract, it is diminished. That is because progesterone relaxes smooth muscle. That's one of the really great things about progesterone. It has a calming or relaxing effect on smooth muscle. Well, you know that the muscle in the gastrointestinal tract, smooth muscle, and when you relax it, that means it doesn't contract. That means it stays in the gastrointestinal tract. We don't have our peristalsis and all that kind of good stuff. So that is what actually contributes to constipation for some women. Heartburn. It's a problem in the third trimester, and that's because the gravid, which means the pregnant uterus, is moving up high. So it's moved past the belly button and it's now moving towards the liver and getting up there and moving everything out of the way. And the stomach will be displaced also. And so that displacement of the stomach will affect the cardiac or gastroesophageal sphincter and therefore promoting acid reflux, which will cause heartburn. During this time, women will find that pillows are their best friend, and they'll make a little nest in the bed trying to actually create a position that is more comfortable for them during their last trimester. Urinary symptoms. Yes, increased urination or frequency of urination is due to a couple of things. Uterus pressing on the bladder will contribute to it, but also the women are extra vascularized, which means they have more blood volume, and that's because their system is responsible for more things than their own. So remember, their digestive system is going to be taking nutrients, harvesting more nutrients to actually feed to the fetus, as well as taking care of waste products that are coming from the fetus as well as their self. Respiratory system. I've never met too many women that have this problem, but there are some that have a very sensitive abundancy of estrogen receptors on their nasal mucosa, and with elevated estrogen levels can have a lot of nasal stuffiness. Shortness of breath, that's also due to the expanding gravid uterus pushing everything up and out of the way because it's occupying the abdominal pelvic cavity, the organs that are there, you know, too bad, so sad, move. And so what happens is this makes it difficult for the diaphragm to effectively flatten out, and so that shortness of breath is also one of the symptoms that are experienced because of that limitation to diaphragmatic activity. And then down here, the very last one, number 4, cardiovascular system. This is where the bulk of the changes occur for everybody. Everybody has this. And that's because total body water rises. So total body water rises. And 24 to 40% increase in actual blood volume is there. So remember, how many liters of blood in a guy about? 5, and therefore 4 in women. And so if you say 40% increase in blood volume, you went from 4 to what? You've added up, you know, you have more intravascular blood in your blood system now than even a man does. So you've added over a liter of extra fluid into the bloodstream. The bulk of this, 50% of this, is actually due to increased plasma. Remember, plasma is the fluid part of our blood. And so this actually is one of the causes for the anemia that women have. So if you have a container and it's got like 10% sugar in it and you add more water to it, that sugar concentration diminishes. And so that's called dilutional anemia. So the anemia that typically results is due to dilutional effects. It is still treated because we want to pump up mom's red blood cell count because she's going to lose a lot of blood with the delivery of the baby. And so prenatal vitamins typically contain the precursors necessary for good, healthy red blood cells. Iron, vitamin B12, folic acid, things along that line. So those are helpful in taking care of what will now be perceived by the kidneys, right, as anemia. And the kidneys will be releasing erythropoietin, and erythropoietin will stimulate the bone marrow to make more red blood cells. And so that dilutional anemia is still actually appreciated by our system. And so the system still wants to actually beef up the red blood cell count. And as I said, this is very important because delivery is a bloody event. So we want to make sure that we have enough blood to take care. In essence, we're trying to do our own autotransfusion in advance, correct? We are trying to make sure that we have enough blood volume present so that when we have the normal blood loss that occurs during delivery, that we don't have to suffer any serious consequences of that. Varicose veins, one of the very unfavorite events of pregnancy for some women. So this gravid uterus is in the pelvis, and we actually have internal iliac arteries and veins. Which one is easier to compress? Veins. And this is where varicose veins come from. So we're applying compression from above, and so we get decreased venous return. And as that gravid uterus grows out of the pelvis, it's going to be in the abdomen. And it's going to cause women to not like to lay in a certain position. You guys have any idea? On their back, yes, because it's compressing the IVC. And when you compress the IVC, that's a major reduction of blood volume. So women like to lay on their sides, you know, whenever the pregnancy has actually risen up out of the pelvis. All of these things, though, you have to realize this expanding tumor in the abdomen, and a tumor is a foreign body, and this is indeed a foreign body. This expanding tumor in the abdomen is compressing and moving things out of the way. Well, you can't move the IVC out of the way. So it gets compressed, and so you have your tourniquet effect, and that will cause some varicose veins for some individuals. The varicosities that a lot of women get that they don't talk about are called hemorrhoids. because they get varicose veins of the anal canal, and that's what actually her hemorrhoids actually are. On to the blessed event, labor and delivery. Let's get this over with, she's saying. And indeed, parturition and delivery or birth typically starts around 280 days after last menses, always plus or minus, depends upon the individual's cycle. And estrogen levels are at their highest. Remember that estrogen levels during the formation of the follicles in the ovaries? Remember how that peak estrogen level had a big effect and caused ovulation? The estrogen level here also has a big effect. So this peak estrogen level is actually going to be part of the initiation of labor. So we have with this estrogen the production of oxytocin receptors on the myometrium. Myometrium, remember, is a smooth muscle of our uterus. And so now we're putting oxytocin receptors on them. And that's because a chemical called oxytocin is going to bind to them and cause them to actually want to contract. But first off, we have to put oxytocin receptors there. So that's what the estrogen is going to help us do. I also told you just a little bit earlier that progesterone relaxes smooth muscle. That's one reason for the constipation of the gastrointestinal tract. And that's what progesterone is also still doing here. As the pregnancy is continuing on to develop a mature fetus, the progesterone levels are trying to say, wait, not yet. The oxytocin receptors are going, oh, I want to do it now. And that progesterone is saying, no, wait, not yet. Until we get sufficient oxytocin receptors and progesterone levels start to actually go a little bit down. Now, because of this, we get what's called false labor or Braxton Hicks contractions, because we've created this kind of teeter-tottering system where it's like, do you have enough progesterone to take care of the irritability that the oxytocin receptors are actually now creating? And that's what Braxton Hicks contractions are. It's all this kind of oxytocin receptor and progesterone level imbalance at times. And somebody's kind of winning out, but kind of is the word, not really winning out. And you can always, unfortunately, tell a woman when she walks into the labor and delivery department of a hospital, you can always go, oh, I feel sorry for her. She's coming in, she's smiling, she's happy, I'm in labor. They don't come in smiling and happy when they're really in labor. You know, so that's the key. She's all excited, oh, yay, I'm in labor. And it's like, nobody goes, oh, yay, I'm in labor. Oh, yay, I'm hurting. Nobody does that, you know, unless they've got some sort of psychological problem. So they walk in and they are not in real discomfort, and they think they're in discomfort, but that's not real discomfort, because real labor is real discomfort. And they come in and because, you know, they want to be in labor, and everybody wants them to be in labor too, because they want to get it over with. You know, you have them come in and you have them hook them up to monitor and let them be monitored for a little bit. And then check their cervix, no change, and you say, I'm sorry, that was false labor, you go home. And the sad faces follow, and they go home. But then they understand a little bit more about that this is just kind of priming the pump, getting things ready. Because what it means is, right, oxytocin receptors are there. This is what it means. We're getting good oxytocin receptor production, which is going to be important for oxytocin. And oxytocin is going to be produced by two people in this process, and I bet you didn't realize it. It's not just maternal oxytocin, it is actually fetal oxytocin. So indeed, it is the fetus that actually is the ultimate key to starting this process. Mom's got everything ready, but the fetal oxytocin has to be produced in order for the placenta to produce prostaglandins. So there is another key player here hormonally. Prostaglandins are hormones. And so prostaglandin production needs to occur for true labor to actually occur. And fetal oxytocin is going to be produced, which is going to cause placental prostaglandin production. Now, mom's producing prostaglandins too, but it's not her prostaglandin that's important for, it's not her oxytocin that's important for the prostaglandin production from the placenta. So, with prostaglandin, oxytocin does this too, but prostaglandin is really actually very good with this. It stimulates strong uterine contractions. So prostaglandin and oxytocin both do this, but I tell you what, prostaglandin is a pretty strong player in that. Whenever there is a delivery via C-section and you have what is called a boggy uterus, can you visually understand what I'm talking about when I say a boggy uterus? Do you think boggy uteruses bleed more than non-boggy uteruses? They sure do. So if you have a boggy uterus after delivery of the fetus, now the newborn and the placenta, and it's not clamping on down, you take a needle of prostaglandin, you just stick that right into that myometrium, and it just suddenly goes, whoop, 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 comes right on down. So prostaglandin is a very strong agent to promote uterine contractions. Now, when the uterus contracts, it's going to be kind of like a peristalsis from the fundus on down. It's going to squeeze the contents to the cervical canal, because that's where you come out under ordinary circumstances. So squeezing the contents down to the cervical canal means the presenting part is going to apply itself to the cervix and cause it to stretch. This stretch actually creates a reflex arc, which will actually cause more maternal oxytocin production. So these guys are working together. They're working in tandem for strong, effective uterine contractions. So we'll have a positive feedback. More cervical stretching, more oxytocin production, which of course will cause more cervical stretching and more oxytocin production. The cervix will dilate to full dilation is typically referred to as 10 centimeters, but if you were actually doing an exam, you would actually go in and try and feel for the cervix, and you will not find it. It is gone when the cervix is fully dilated. All you'll find is the presenting part, which is typically the head. That's right. And so that's always the best. The head is always the best because it is, under ordinary circumstances, the largest part of the newborn. And so you want that cervix stretched by the thing that's the biggest. If you have a breech presentation, the butt and the legs and the thighs are nowhere near as big as the head. And so the problem with breech presentation during delivery is body comes out, head gets stuck. And so that's why breech presentations are typically not something that's preferred. A lot of people will go straight to a C-section delivery. But if you have a very well-experienced obstetrician taking care of you, they easily go ahead and take those babies on out without any problems or trauma to the cervix or the woman. It's just uncomfortable if you don't have any analgesia on board. But having a baby is typically considered uncomfortable too. All right, so prostaglandins and oxytocin is absolutely necessary for true labor. So E is important because E, estrogen, is making oxytocin receptors. So without the oxytocin receptors, you can pour as much oxytocin in as you want, nothing will happen. And as a matter of fact, for women who don't go into labor, they try to induce labor. What do they give them? Do you guys know? Pitocin. What does Pitocin sound like? Oxytocin, and that's what it is. It is oxytocin. So obviously it's very effective. But if someone comes in and you're trying to induce labor with Pitocin and it doesn't work, what do you know? They don't have enough oxytocin receptors. And so the estrogen level isn't high enough for those oxytocin receptors. And so a couple of days later, they come back in and you try and induce them again and it works. What do you now know? Plenty of oxytocin receptors, even in a few days. So that is why some things work and why some things don't work. And so knowing this physiology here is actually pretty cool, I think. I don't know what you guys think. I'll find out with that exam, I guess. So because prostaglandins are important also in the initiation of this process, we really tell women who are pregnant, don't take any medicines over the counter. Isn't that what typically is said? Take nothing. And they go, well, what if I have a headache? Okay, you can take Tylenol, but that's it. You know, that's pretty rough in our society because we're not used to much discomfort. The reason that we say don't take anything is because there's so many anti-prostaglandin medications out there that are OTCs, over the counters. And so ibuprofen, Aleve, Naproxen, NSAIDs, NSAID, non-steroidal anti-inflammatory drugs, and even aspirin is a really strong anti-prostaglandin. So anti-prostaglandins will actually interfere with the actual initiation of true labor for an individual. So you don't want to have those things in the mix. And so it's just best to say, just don't take anything, because then you don't have to explain which things not to take. So it's short, simple, and sweet. Most people actually understand. Don't take anything. Don't drink. Don't smoke. Don't have coffee. You just go, my life sucks. So, get this baby out of me, you know, so. And so this is now real labor. So there's 3 stages to real labor. Stage 1, 2, and 3, that part's easy. Stage 1 is called dilation of the cervix. Stage 2 is expulsion of the fetus. And stage 3 is placental, which is delivery of the placenta. So stage 1, dilation of the cervix, is indeed the longest and most variable stage. It is defined as the time of onset of true labor to full cervical dilation, and that should be, it's basically 10 centimeters. What will happen is the uterus will actually have a peristaltic wave from the fundus on down, so it's literally trying to squeeze the baby out from top on down. The contraction frequency will actually increase as well as the intensity. The cervix does this first in true labor. It thins. Remember we talked about the cervical canal full of mucus, that's the mucus plug that keeps the nasties of the world outside of the uterine cavity. Well, it has length. So we have the external os, which is vaginal, and we have the internal os, which is endometrial side. And we have to make that, I'll liken it to a donut, like one of those small donuts that you can get in those little packs at the grocery store. You know, those little round things, and they barely have a hole in them, an opening in them. That's kind of like the cervix. It looks a lot like that. And so you have to flatten it. So in order to flatten it, you have to sit on it. That's what the fetal head or the presenting part is all about. So you flatten it first, which is called effacement. And then because it's flatter and thinner, it's easier to open it up or cause the dilation. So effacement occurs first. So that's the thinning, and then it's easier to dilate. Amnion ruptures. Well, that's the amniotic sac that we're talking about. This typically occurs during labor. Some women, their amniotic sac will actually rupture before they go into labor. And that's not a big deal because typically you will go into labor, but if you don't go into labor, that can be a problem, right? Because the amniotic sac means now what if it's ruptured and you don't go into labor? It means there's little nasties that can get to the baby, correct? And so that's why rupture of the amniotic sac without going into labor is not considered a happy event, and typically people go to the hospital and get monitored and they try to induce labor for those types of things. But that's typically what happens during labor. There's always extremes, you know, differences that are not considered ideal. Let's put it that way. I said ideal. I didn't say not normal. So amnion ruptures, which means the volume of fluid leaves, which means now it's even easier for the uterus to grab that baby and go squeeze you on out. So labor can last from 4 to 24 hours. And everybody knows somebody that had a 36 or 48 hour, you know, labor time. Those are, you know, you just have to feel sorry for those people because they are getting hit every 2 to 3 minutes with this wave of powerful uterine contractions. That doesn't feel good. That's why I say when they come in smiling, you know that this is not going to bring forth the blessed event. When they come in frowning, you go, you're in labor. Okay. Yeah. There is a reason why they have those, you know, on these TV shows, they go show. They're not smiling when they're doing that, if you've noticed. So engagement occurs. Infant's head is in the pelvis. Obviously, it has to be after that cervix dilates. It literally does plop right on down there because that was the only thing holding it back. The cervix is no longer holding it back, and so the head plops on into the vaginal or birth canal, and then we end up with that next stage, which is stage 2, expulsion. Because we have engaged and we are in the vaginal area and we're still being squeezed out from the fundus on down, we will actually start to distend or stretch the perineum. And I often describe this as a bowling ball coming out of a woman's vagina. And so that's kind of like what it is, because the baby's head is pretty big and it's typically kind of round, gets a little smushed because it has those sutures that haven't solidified, which is there on purpose. That's why those sutures have not solidified, because we will actually, in order to get those little heads into somebody's pelvis, those little bones, parietal bones, will sometimes have to ride up over one another in order to squeeze that little head through a birth canal itself. So contractions are there, and I'll tell you what, you can just about depend on it without examining a woman when she says, I gotta push. You go, I bet she's fully dilated. without even examining them. You can examine them and you can pretty much verify she knows what she's talking about. It's time to push. Cervix is gone. She wants to push, and then crowning occurs. Again, bowling ball is at the vestibule, at the perineum, and it is distending that. You can see that whether or not your baby has hair, what color it is, all that kind of stuff through the vestibule, or basically the opening of the vagina is getting bigger and bigger and bigger all of a sudden. Now, this stage is a stage that, if you have patience, will actually proceed naturally with the distension. If you allow for a slow, gradual distension of the perineum, the baby can be delivered without having to do an episiotomy or other types of techniques that interfere with the process. They interfere in a positive way. An episiotomy means baby's here faster. So the baby's distending this, but you have to understand, perineum, the other side of the perineum is the anal canal and the rectum. And so what happens is, most babies come out, do you guys know, face down, face up, turn to the side, face down. So that's one reason too why they have those nice little flat noses when they first come out. Now, they have, the longer they're also in the birth canal, the puffier their head gets and the more they have these little cones on their heads. So what they're doing is they're making their descent. Their head has to truly make it through the pelvis. And so they're facing mom's sacrum. What's between their face and the sacrum? The rectal canal, right? So that face is scraping along that sacrum and pushing poo on out. So sometimes women will have defecation before they have delivery of the child. And you will actually see the anal canal and rectum, actually, not rectum, but the anal canal and opening kind of dilate too. And when you see that dilating, you know baby's almost ready to come on out. So baby cunt, does this sound like fun? Don't I need to go to the high schools and talk to kids about pregnancy? Yeah. So baby's coming out face down, comes out face down, and the next thing that has to come out are the shoulders. This is what's called shoulder dystocia if you have somebody that has gestational diabetes, because that means that you are actually not delivering just a normal baby, you're delivering a football player wearing shoulder pads. So all babies come out, not all, but some come out face up, which makes for a more difficult delivery, but the majority of babies come out face down and then they turn. And they turn to face the side. And the reason they turn to face the side is that actually increases their chance of going under the symphysis pubis. And so what I call the anterior shoulder, anterior on mom, then you just do a little downward head traction, anterior shoulder comes on out, and then a little upward head traction, head neck contraction, and posterior shoulder comes out, and you have the baby in your hand. And if you miss, it's because you're just not standing in the right spot. So, and you don't have to worry because they have a bungee cord attached, so they don't fall. So that's expulsion. And so then you take the baby and you put the baby on the mom's chest and belly, because that's kind of what our society is trying to do, trying to create early bonding. And you want to bond after that kid came out because that kid didn't make you feel very good on the way out. So we're trying to make for happier moms, this is what it was all for. And put it on the chest and you clamp the cord and you cut it. And then all kinds of things are happening physiologically with the newborn. And we'll talk about that in just a moment. Okay, placental delivery. So baby's on the chest, that means something else is left behind, and that's placenta. The life support organ has now been severed from the newborn, or neonate, however you want to call that. And we have to deliver the placenta. And the placenta, remember, is part fetus and part mom, right? Isn't mom part of that placenta? And didn't I tell you that we actually have placental capillaries going into mom's mushy blood vasculature for nutrients? This is where the blood loss comes from. So babies, it's not just from, a little bit of trauma to the birth canal. And there's sometimes a lot of trauma, but compared to what's actually happening inside the womb, inside the uterus, the trauma where all the blood loss comes from is inside the uterus itself, where the placenta is. Now, remember, this area had a human body in it, correct? Now the body's gone, and what should the uterus now be doing? Still contracting, and it does, because it's this huge space that shouldn't be a space anymore because its contents are now gone. So contractions still continue. And so the uterine contractions continue, but instead of pushing something out, it gets smaller and smaller and smaller. And in doing this, what happens is, this is my arm here is the inner uterine wall, and my hand that I'm applying to it is the placenta. And as this gets smaller and smaller, the placenta doesn't get smaller, so it shears off. And so the placenta shears off and leaves a gaping, bloody wound. Because remember, it was reaching into mom's vascularity for the nutrients. And so you have this big, gaping, bloody wound. But that's what's really cool about those contractions, because those contractions, in addition to shearing off the placenta, are doing its own little auto tourniquets to all those bleeding areas. So this is a natural and normal part of placentation or delivery of the placenta, and so it takes a little bit of time. This is also the time where you wonder, where does the fetal and maternal blood mixing come from that causes RH incompatibility? Folks, this is it. This very big event of getting that placenta off the inner uterine wall is actually where that mixing actually can occur and cause mom's RH problems with the newborn. Now, adjustment of the neonate after birth. So neonatal time period is the first month after birth. And there's a couple of things that have to happen in order for the first breath to occur. Because now that we've detached them from the placenta, which was their oxygenation kind of unit and stuff like that, their pseudolungs, they need to start using their own lungs. And so this is why you don't like to give women sedatives or pain medication that affects their CNS system. Because if it affects their CNS system, it will affect the fetal CNS system. And so that's why you don't want to give opioids and Demerol and morphine and all that stuff, at time of delivery, because you're depressing the neonate CNS. Because when you're depressed and somebody pokes you, do you do anything? When your CNS system is depressed? No. So that's why in the notes here, CNS is important. A normal functioning CNS is important. If you have infection, CNS can be actually impaired too. So all of that is important, because now you went from a nice, warm, wet environment to a cold, cruel world. And you notice it. And most people who go from a nice, warm environment to a cold, cruel world will scream at you. And that's really good. You want them to do that. So that's part of the stimulus. You don't have to stimulate a baby to scream. They should scream. Because what the heck is this? So now they've been delivered, and they have a normal functioning CNS. And that's why major environmental and temperature changes. Nice, warm, soft, dark environment. Now hustle, bustle, and cold and rough. And also, carbon dioxide is going to accumulate, because when you don't breathe, you guys all know, CO2 levels go up, correct? So CO2 levels go up, so that creates an acidosis. An acidosis is a very big stimulus for us to breathe, okay? And then the lungs, you have to have enough surfactant, because these lungs have never expanded, so they're considered like collapsed. So they're all crinkled up and never been stretched out or any of that type of stuff. And so now we want to stretch them out. And in order to stretch them out and not to have them collapse again, you have to have surfactant, because surfactant, remember, is important in preventing collapse of our little alveoli. So when the newborn takes the first breath in, then you can imagine all these little balloons going, boop, 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 opening up. And then you breathe out, exhale, and you don't want those little balloons to start collapsing. And the next breath you take in, more balloons open up. And the next breath you take in, more balloons open up. And so as they breathe, their lungs open up and become more functional, and then are able to adequately oxygenate them. So surfactant, very important to prevent alveolar collapse. Amniotic fluid is also in the lungs, and that's what's really interesting. Gosh, do you guys know what amniotic fluid actually really is? It's what?
Is there like kind of sugar water?
No, it's pee. It's urine. Amniotic fluid is actually urine. And what do you know about fetal urine? Sterile. So NBD, no big deal. So that amniotic fluid is indicative of actually normal, healthy kidneys. because there are babies out there that do not have normal healthy kidneys. And what do you know about, when I tell you that now, what do you know about their amount of amniotic fluid? It's really low, and so they always worry about babies with low amounts of amniotic fluid because that amniotic fluid comes from normal, healthy, functioning fetal kidneys. So, also, amniotic fluid can sometimes not be clear, because isn't it supposed to be clear? Yeah, and if it's not clear, what is the color that it can be? It can be kind of what I call green-brown. That green-brown color is called due to meconium contamination. And meconium is poo. And it's fetal poo. And it's thick, tarry stuff. And so it gets mixed in with the amniotic fluid. And remember, the lungs are full of amniotic fluid. And if you have a lot of poo in that amniotic fluid, it acts like a sticky slime and does not allow for adequate oxygenation and carbon dioxide transfer. So that's why they don't like to have meconium-stained amniotic fluid, because it puts the fetus at risk, the newborn at risk for respiratory complications. Occlusion of fetal vessels and shunts. Umbilical arteries become our medial umbilical ligaments. Remember, belly button, okay? And so what's really interesting, these umbilical arteries come off of the internal iliacs and run along the inner aspect of our abdominal wall to our belly button. So we can actually see in you the medial umbilical ligaments if we were to take a laparoscope and look around. The umbilical vein becomes that round ligament of the liver. The ductus arteriosus is going to collapse because there's going to be this big change in pressure differential. Because previously it was hard to get blood into the lungs. Well, now we've opened up them and we've basically allowed for easy perfusion of the lungs, so it's not difficult, and that's going to cause major pressure changes as well as oxygenation levels. Because remember, what were our oxygenation levels prior to delivery? Always lower than ours after delivery. And so that ductus arteriosus is going to have a high O2 hit to it and become the ligamentum arteriosum. Foramen ovale becomes a fossa ovalis. This is the last shunt to actually close and takes several months to do this. Lactation, prolactin, aha, this is the one that makes milk. Estrogen and progesterone prepared the factories for milk production. Prolactin says start milk production. And the first secretory product is called colostrum. And it's a small amount, doesn't have much lactose in it, doesn't have much fat in it, does have a fair amount of protein in it, and it's not high in volume. And that's why babies are supposed to have a lot of sub-Q fat, because this takes care of that little bit of forced lack of nutrition in the first couple of days. Colostrum is also rich in immunoglobulin A. Remember, this is going to help to protect the baby that we've now put it into a nasty bacterial and virally rich world. The nice thing too about colostrum, it has a natural laxative effect, which helps to get rid of that nasty, sticky, tarry, black, green stuff that comes out of the baby's rectum and anus. Likes to stick to it. It's always a lot of fun to wipe it off, and you know what, if you've ever done it, you know exactly what I'm talking about. It's just bile and a bunch of cells from the gastrointestinal tract, and obviously amniotic fluid, because also they swallow their amniotic fluid. Infant suckling causes actually direct stimulation to the hypothalamus to keep prolactin being released. So the suckling of the infant says hypothalamus, more prolactin, and also stimulates pulsatile oxytocin release. And oxytocin is going to help get that uterus to continue to get smaller and smaller, because it isn't going to be 24 hours after the baby's delivered that big uterus that was up under her lungs is now going to be down there just in the pelvis itself. So oxytocin will also help keep that uterus getting smaller and smaller as time passes by. But it is interesting, around the lactiferous units we actually have some smooth muscle, and then oxytocin will stimulate that smooth muscle to contract. We have a little bit of milk ejection, commonly called milk letdown. It's a much nicer term instead of saying milk squirts out of the nipples. But it actually can, in some women, do that. And certain things will also stimulate milk letdown, not just the suckling and the oxytocin, but actually even the thought of the baby needing to be fed, because when the baby starts to cry, a lot of women will actually experience that milk letdown itself. Human milk, much higher fat content than colostrum, and that's why some of these babies, I mean, some women have a lot of fat in their milk, and that's why some of these babies you see look bigger than the Pillsbury Doughboy. I mean, it's just like, oh my gosh, Buddha, you know, wow, what rich breast milk, honestly. But there are some women that do not produce that much fat in their breast milk, and so they have what a lot of people will refer to as blue milk, and that's just an FYI type of a thing. But you know, that breast milk is usually has a fairly high fat content and is very nutritive overall. Lots of immunoglobulins. So obviously I mentioned IgA, but even more immunoglobulins are going to be in the breast milk, and lots of vitamins except for vitamin D. Seems a little punky on vitamin D, and so that's why they recommend supplementing newborns with vitamin D drops, which you guys know is important for normal, healthy bone formation. An interesting thing about nursing. Nursing causes the release of beta endorphins. What do we know? What are beta endorphins? Makes you feel good. So in other words, nursing makes you feel good. So these beta endorphins are released, which is interesting, is that they inhibit gonadotropin-releasing hormone. If you inhibit gonadotropin-releasing hormone, what do you know? You also have, which means low levels. What other anterior pituitary hormones are going to be low? FSH and LH, they're going to be nice and low. So what do you know about follicle development then? No follicle development. What do you know about estrogen levels? Actually kind of low too. What do you know about baby blues? High. Think about the hormonal shifts this individual is having to undergo not long after delivery of the baby. High, peaking estrogen levels, and now down on the floor. You know, be nice to these ladies. They need your help. You know, so strict breastfeeding can be hard to stop for some women. Yes? Can you understand now why? They have a lot of beta endorphins being produced, and so therefore, who wants to get rid of their beta endorphins? You know, because to them, you know, this is being made by me. This is my natural opiate. You know, so it's one of those issues for some people. Now, also, what do we know about some women that love to do marathons and run every day? Why do they do it? Because of the beta endorphins. So if the beta endorphins of these women that run every day are elevated, what do you know about their estrogen levels? Also low. So all of these things are kind of interesting when we talk about labor and delivery and breastfeeding and all that stuff that happens afterwards. So that's the end of the material for this semester. I hope you have enjoyed our discussions about pregnancy and delivery, and I'm happy to go to any high school and talk to kids about it. We'll stop our recording there.